Hi everyone, welcome back to Izzy Medicine. This is part 3 of the 3-part EKG series. Today in part 3, we're rounding it out with the rest of the high yield patterns that we need to recognize fast and confidently. So grab a pen, maybe your emotional support coffee, and let's decode the final chapter of rhythm mastery. Let's start with hypertrophy and enlargement because size does matter. At least when it comes to atria and ventricles. Let's address left atrial enlargement. So what we're going to see in left atrial enlargement is in lead 2, we will see a wide notched P wave, that classic M shape. Why do we see this? It's because an enlarged left atrium takes longer to depolarize. It's stretched out, so the electrical signal moves more slowly through it. So the right atrium still fires, and it fires first, but now the left side is lagging, and the delay shows up as a second hump. In lead V1, you might spot a biphasic P wave, and this time the second half, the left atrial component, is deeper and wider. Again, that's the delayed depolarization of the enlarged left atrium, and it's dragging out the signal. What causes an enlarged left atrium? Chronic hypertension is a major culprit. When systemic blood pressure is high, the left ventricle has to pump harder to overcome resistance. Over time, it adapts by thickening. It becomes hypertrophied and stiff. What happens, that stiffness makes it harder for the left atrium to empty into the ventricle, so the pressure backs up. So not only is the pressure backing up because of difficulty, and the atrium now has to work harder to push blood forward as well, and eventually it enlarges. Mitral valve disease is another big player that can cause left atrial enlargement, and the mechanism here is in mitral stenosis specifically, the valve is narrowed, so the atrium has to push against kind of like a bottleneck, tight opening, and that's pressure overload, so it enlarges. And in mitral regurgitation, with every ventricular contraction, blood leaks backwards. It floods the atrium with extra volume, and that's volume overload. And that enlarges the left atrium by stretching it. Either way, the atrium stretches to compensate, and that stretch slows down its depolarization, and it shows up on an EKG as a widened or biphasic P wave. So that's our indication on the EKG of left atrial enlargement. All right, now let's flip to the right atrium. What we're going to see in right atrial enlargement is in lead 2, we're going to look for tall peaked P waves over 2.5 millimeters in size. Why does this happen? That's because the right atrium is enlarged, and with more muscle mass comes more depolarizing tissue. So the electrical signal is stronger and travels farther, and this creates this taller deflection. In lead V1, the first part of the biphasic P wave, which reflects the right atrial activation, that becomes more prominent for the same reason. Why does right atrial enlargement happen? It all comes down to pressure overload in the right side of the heart. So chronic lung diseases like COPD cause low oxygen levels in the alveoli. In response, the pulmonary arteries constrict. It's a reflex known as hypoxic pulmonary vasoconstriction. Over time, this constriction raises pressure in the pulmonary circulation and leads to a condition known as pulmonary hypertension. So, because of pulmonary hypertension, the right ventricle now has to pump against a higher resistance to move blood into the lungs. And that chronic strain can cause it to work harder, and that eventually leads to backward pressure into the right atrium. And to keep up with this backward pressure, the right atrium stretches and enlarges, and that shows up on the EKG. You can also see this in an acute situation like a pulmonary embolism, and here a large clot suddenly blocks blood flow and it causes a spike in pressure. The right ventricle strains to overcome it. It pushes against that pressure, and that pressure again backs up into the right atrium, and the right atrium dilates in response, but this is an acute right-sided strain. Now let's zoom in onto the left ventricle, the powerhouse that pumps blood into the entire body, and let's discuss left ventricular hypertrophy. If systemic blood pressure is chronically high, the left ventricle has to work harder to push against all that resistance. What does the heart do in response? It adapts. It adapts by growing more muscle. That thickened wall generates more electrical activity, and that shows up on the EKG as increased voltage. So what does LVH look like on an EKG? So here we have an S wave in V1 plus an R wave in V5 or V6 that adds up to more than 35 millimeters. And that's 7 big boxes. Again, this is because of a larger muscle creating larger voltage. Also, we can see an R wave in AVL that's over 11 millimeters, and that's another common clue. You may also see a strain pattern, such as ST depressions and T wave inversions in the lateral leads like V5, V6, 1, and AVL. And that reflects subendocardial ischemia because the thickened muscle isn't relaxing well and it starts to outgrow its own oxygen supply as it thickens. What's the most common cause of LVH? It's long-standing hypertension. Because of all that pressure, the ventricle gets stronger, yes, but also as it gets bigger and stronger, it becomes stiffer. And that stiffness can lead to more arrhythmias, ischemia, and even sudden cardiac death. So LVH increases the risk for sudden cardiac death. So when you see these voltage changes, it's more just an EKG pattern. It's a red flag for long-term cardiovascular risk. Now, let's shift and talk about right ventricular hypertrophy. So normally in lead V1, the R wave is small and the S wave is deep, because the left ventricle dominates the electrical signal. But when the right ventricle hypertrophies, this pattern can flip. In RVH, the R wave in V1 becomes taller than the S wave, a reversal of their usual voltage pattern. That's a sign that the right ventricle is no longer tagging along, it's actually taking the lead electrically. So what causes this? Anything that increases pressure in the pulmonary circulation, just like we saw with right atrial enlargement. Chronic lung disease causes hypoxia and causes pulmonary vasoconstriction, which we just discussed, and that leads to pulmonary hypertension, and that increases the workload on the right ventricle as it has to push blood into the lungs against a high gradient. And then on the acute form, a pulmonary embolism creates an acute spike in resistance, and that suddenly strains the right ventricle. So in response to these chronic or acute strains, the right ventricle thickens to generate more force, and that increased muscle mass shows up on the EKG as a dominant R wave in V1, and often along with right axis deviation, which we reviewed in a previous lecture. So the bottom line is, if the right ventricle is doing the heavy lifting, the electrical pattern will reflect it, and that's our clue to RVH. Now, let's move on to talking about electrolyte abnormalities. So electrolyte disturbances can sneak up and wreak havoc on EKG, especially in sick patients. Why does this happen? Well, electrolytes like potassium, calcium, magnesium, they play a central role in cardiac action potentials. If they're off, depolarization and repolarization gets disrupted, and the EKG reflects that. So let's discuss hyperkalemia. Potassium affects membrane potentials, and when it's too high, it makes cells more excitable, but they're also slower to repolarize. So what happens is you get diffused, tall, peaked T waves. They're tent-like and symmetric. And as it worsens, the QRS widens, and you may see a sine wave pattern eventually. It's a signal that repolarization is prolonged and conduction is slowing. Think about things like renal failure, ACE inhibitors, or massive cell breakdown with tumor lysis, rhabdomyolysis, or even crush injuries. On the flip side, we have hypokalemia, when potassium is too low. And what happens there is the heart's repolarization becomes sluggish and unstable. That shows up as flattened T waves and the appearance of U waves. They're extra little bumps that follow the T wave. Low potassium also increases the risk for arrhythmias, like Torsades de Pointes. So why does hypokalemia happen? Potassium loss can occur through renal losses from diuretics, diabetic ketoacidosis that we've talked about, hyperaldosteronism that we've talked about before, or non-renal losses like vomiting, diarrhea, or excessive sweating, and this can all leave the cardiac electrical system depleted and irritable. So if you see signs of hyperkalemia and hypokalemia, think about what conditions we can rectify. Lastly, we have the digitalis effect. So if our patient is on digoxin, we might spot a very distinct EKG change. The ST segment takes kind of like a scooped appearance, and it's often called a Salvador Dalí mustache, as you can see here. This isn't a sign of ischemia. It's actually a known effect of the drug and reflects how digoxin alters calcium handling and repolarization in the heart. But here's the catch. While this dig effect is actually usually benign, toxic levels of digoxin can be dangerous. They can trigger serious arrhythmias, they can trigger AV blocks, ventricular ectopy, or even tachyarrhythmias. So if the EKG starts showing sagging ST segments and the patient is on digoxin, it's not a STEMI, but we don't ignore it either. We check the digoxin level and be on the lookout for symptoms of toxicity. So the moral of the story is essentially when the EKG looks weird, check the electrolytes and don't forget to scan the med list. Alright, so we've talked about how electrolytes can throw off an EKG, but they're not the only mimics. Up next are two patterns that can really trip up people. So pericarditis and early repolarization. They both can cause ST elevations and kind of look like a STEMI, but they're not. And knowing how to tell them apart can save your patient from an unnecessary trip to the cath lab and also lead to the right diagnosis on top of everything. So let's break them down. So pericarditis is exactly what it sounds like. It's an inflammation around the pericardial sac. And when the whole heart is irritated from this inflammation, you can see diffuse ST elevations across many leads. So lead 1, 2, 3, AVL, AVF, V2 to V6. The ST elevations tend to have a concave kind of smiley face shape, not the tombstone pattern of an MI. And one of the most important clues, there's also PR segment depression, especially in the same leads where the STs are elevated, and that reflects atrial involvement from the inflamed pericardium. You usually won't see reciprocal changes either, another way to distinguish it from an MI. And from the history, chest pain from pericarditis gets better when the patient leans forward and worse when lying flat. Physiologically, this isn't a localized blockage like a STEMI, so it's widespread current of injury caused by inflammation affecting the outer surface of the heart, which is why the ST elevations show up across multiple leads and not just in one coronary distribution. And this, in addition to the history, signals that it's most likely pericarditis versus a STEMI. Then we have early repolarization, which can look a lot like pericarditis, but it's actually a common finding in healthy young individuals, especially athletes. And here's how we know that it's benign. ST elevations are mostly limited to precordial leads, V2 to V5. Also, they're concave in shape, but there are no PR depressions. Often, there's a notch at the J point where the QRS ends and the ST begins. And there's no chest pain, no evolution over time, and no reciprocal changes. And that's how we differentiate it from a STEMI. And here's the key. Early repolarization is stable. If we look back at an old EKG, it will show the same pattern, and that's their baseline, basically. In summary, pericarditis has diffuse ST elevations with PR depression and positional chest pain, and early repolarization is a normal variant with concave STs without PR depression and no clinical symptoms. All right, so with that, we understand that some patterns pretend to be deadly, like pericarditis, but others are the real deal and are hiding in plain sight. Pulmonary embolism is one of those. So let's break down the clues. Let's start with the classic board favorite, S1Q3T3. What that means is that on EKG, although it's not definitive for pulmonary embolism, we will see a deep S wave in lead 1, a Q wave in lead 3, and a T wave inversion in lead 3 as well. But let's talk about why this happens. We've briefly alluded to it several times with different patterns such as right atrial enlargement and right ventricular hypertrophy. So when a large clot suddenly blocks the pulmonary artery, the right ventricle is faced with a wall of resistance. Pressure builds up fast because the block is sudden. The right ventricle dilates under that acute strain, and the conduction system gets stretched, which is what leads to those electrical changes. What also may happen is that we might see right axis deviation. We might see incomplete or complete right bundle branch blocks as the right ventricle strains and the electrical conductivity slows through that area. And T-wave inversions in the anterior leads, V1 through V4, again from right ventricular strain. With that said, don't forget that the most common EKG finding in pulmonary embolism is actually sinus tachycardia. So zooming out to the clinical picture of this, if we have a patient that has sudden onset dyspnea and chest pain, we see sinus tachycardia, and if we notice that they have a low pulse ox, the EKG may be the first sign that something is wrong before we even get the CT angio. All right, guys, you've made it through all three parts of this EKG series, from rhythm basics to chasing down PEs. So what's next? If you want to take this momentum forward, check out the ACS lecture and you'll see how to apply these patterns of EKG reading to real-time chest pain triage. Or if you want to keep surfing squiggles, you can dive into the atrial fibrillation lecture where the irregular gets interesting. So no matter where you go from there, keep learning, Stay curious. Thank you for learning with me and for being on this channel. Again, as always, if you have any questions or comments, leave them down below. And if you enjoyed this lecture, subscribe and like, because it helps the algorithm a lot. I will see you in the next lecture, and bye.